Top Med Talk.
All right, live from Anesthesiology 2018, we are Top Med Talk on the Smith's Medical Booth. I am Desiree Chappell, host of Top Med Talk, and I have here my partner in crime, Monty Mythen, Editor-in-Chief of Top Med Talk. Hello, Monty.
Hey, Desiree. Good to be here. I think that's our last interview of today in this trade exhibition, as it used to be, Connection Centre. But we are running again later on this evening, aren't we?
We are. We're doing a live event with Smith, actually at the W Hotel, just cat a corner from here. And we're going to be talking about pain and ERAS for elective C-section and some hemodynamic information as well. So all good stuff.
Had a fantastic day today, tremendous engagement. You know, with a lot of the traffic has stopped to join in, which has been really good. Had some great guests, but I think we're just about to have our best one of the day.
It's one I definitely have been looking forward to. So our special guest that we have is Dr. Bobbie Sweitzer, who is the Director of Perioperative Medicine at Northwestern in Chicago. Bobbie Jean, thank you so much for joining us. A repeat guest now on Top Med Talk. We just talked to you a couple weeks ago at EdPom, didn't we?
And I'm so honored.
Yeah.
So I must not have flubbed the first one too badly, or I wouldn't be invited back. Thank you.
It was great. We had a great chat there about anemia and management for our surgical patients. So that was a great conversation.
Yes, with Lori Heller.
Heller. Yeah, it went really well.
And thank you for hosting us, by the way.
Thank you for guys coming. Chicago's a great city. We love to have you there.
I think we booked in for next year.
I think we are booked in for next year already.
Awesome.
So we're going to, it's on the list.
Awesome. We're excited to have you back.
Yeah, thank you. So, Monty, you had a good question for Bobbie Jean about her title and your background.
Yeah, you're Director of Perioperative Medicine. Is that right? So I don't know exactly where you are in the USA at the moment, but relatively recently in the UK, our Royal College of Anaesthetists decided to dive right into the perioperative medicine thing. And there's now an approved curriculum for training in perioperative medicine that includes an advanced module, such that it's now sort of been recognised as its own specialty in the UK. Now, for us as team anaesthesia, it's a subspecialty of anaesthesia, but it's a bit like being a cardiothoracic anaesthetist. You do fellowships in it. Where are you in that journey here in the UK? In the US, sorry. No.
I think we're trying to catch up with you guys.
But you got in first. Perioperative medicine sort of started over here, didn't it? I mean,
it did, but I think we, maybe didn't gain as much traction early on as we would have liked. And I think medicine in the United States is very fragmented, and it's very super specialized. And it's very driven by often, the money. And so anesthesiologists are primarily trained in the United States to provide intraoperative care. And even though we are in pain clinics, we're in ICUs, and we've been, increasingly getting involved with the preoperative medicine and running preoperative clinics, they've always been a little bit the stepchild of the operating room. And so I think it just took us a little time to really appreciate that if you don't adequately prepare patients ahead of time, then you're going to never get the sort of postoperative or intraoperative benefits and outcomes that we're looking for. We also realize that a lot of medicine drops through, patients fall through the cracks with these handoffs of care. And this fragmentation where, a group will take care of them preoperatively and a different group in the operating room and then a different group in the postoperative period. And we really feel like we need to integrate that. And we believe that anesthesiologists are prime individuals based on our training, our experience, our expertise working in the operating rooms, in the ICUs, in the pain clinics, and increasing the preoperative clinics to do true perioperative care.
See, and I know we're going to be talking mainly about frailty in this session, I think, but I think the frail elderly patient has a huge amount to benefit from the perioperative care pathways.
Absolutely. I think, that was a study that came out of Europe that showed that about, 80% of all major morbidity mortality occurred in a population of about 12.5% of the patients. And the, three major things were, age, comorbidities, and the type of surgeries to predict those patients who are at greatest risk. And as patients are living longer, they often think of themselves as, the 80s, the old 40 or, this kind of thing. And they want to have active lives. They want to engage in quality of life measures and they want to have surgeries. And yet I think we're starting to identify that age does make a difference. But then how do you separate out the unusual 90-year-old who can have her fourth major joint, which was an article that I think that got published in, Wall Street Journal a few years ago, from the, 75-year-old who is not going to do so well. And I think it gets down to these things that it's not just age, it's not comorbidities, but how physically fit someone is to survive surgery. Increasingly people are using these analogies. If you can't run a 5K race, if you can't run a marathon, then you probably can't undergo a pancreatectomy or a major spine surgery. We're asking for a response to a stress, the ability to tolerate pain, tachycardia, fluid shifts.
I'd say, isn't that the majority of patients or majority of people can't run it?
Exactly. So then, that's why I think we need to try to help differentiate those patients who are too high risk at the moment to have a surgery that maybe is planned.
Do you objectively evaluate fitness? Because that became very fashionable in the UK, and it's now, I think, Mike Grocott, I can see here. The objective use of who was doing the cardiopulmonary exercise testing workshop in Chicago at Northwestern, is the team anesthesia leading the evaluation of patients objectively using cardiopulmonary exercise testing has become pretty much normal in the UK now.
I don't think cardiopulmonary exercise testing formally is being used as much in the United States because we don't have the settings to do that. We don't have the people who are trained in that total evaluation using bicycles and oxygen uptake and lactate levels and CO2 production. So I think we're using some more practical, perhaps more simplified ways, such as 6-minute walk tests, get up and go tests, formal frailty testing, which I think is still nascent but is starting to get more traction. And I think some of it was that the early studies for cardiopulmonary exercise testing was mixed, the results. It takes a certain amount of resources and time and personnel to do that.
Just want to interrupt there for a second, but so does a 6-minute walk test. I've watched lots of 6-minute walk tests, and it takes quite a lot of real estate, and it takes personnel, and it takes time, and it takes equipment. The illusion is always that it's a freebie. But
I'm not saying it doesn't take time and some real estate, but probably not as much as a formal, complete cardiopulmonary exercise testing.
I wonder if anyone's if anyone's looked at the costing of that properly, as opposed to pretending that it's free because they deployed someone to do the test. I don't get too distracted by this, but I think it's quite an interesting question.
Probably to say, Paul Miles did a 6-minute walk test add-on study to the METS study, which was recently published, which I guess will come out in the next year or so, and he may have some data around that, which will be interesting.
But he did some health economics on it as well?
So I don't know, but it'd be worth asking.
Because it's definitely not free.
It's not free, but for example, in our perioperative clinic, we do our frailty testing is done by a medical assistant.
Right.
I don't know, how that sort of translates in the UK or outside the United States, but a medical assistant is someone who is, much less training than a nurse, and much less training than the physical therapist, and they're the typical person who rooms you and takes your blood pressure and measures your pulse oximetry with the machine that they clip on your finger.
Yeah.
So the personnel costs are the lowest personnel costs in our clinic.
I didn't want us to get distracted by a battle of the tests, but the fact you're doing a formal frailty test, a get up and go test, and a 6-minute walk test, you're already in a very different league to very many people evaluating patients.
Here in the U.S., for sure.
Absolutely, I agree. That's why they invite me to come and have these interviews and talk. I'm cutting edge.
It is. And how have you seen it reduce complications and issues with outcomes since you've implemented these types of things?
So partnering with one of our surgeons who is a champion of this, and our initial data, which we have not published yet, shows that in line with, I think, what was published just recently in JAMA Surgery, showing that just simply identifying a patient as frail or pre-frail, we've shown decreased length of stay for the surgeon pilot group that we're feeding that information to. we're showing that some of the patients and their families are willing to engage in discussions about different surgeries and being better prepared to anticipate whether they can go home or not go home, and whether they're going to need assisted care at home or they need to go to a skilled nursing facility, whether they need, interventions just because they live on the 4th floor of an apartment building in downtown Chicago and they don't have an elevator. We haven't had it in place long enough to look at more objective outcome measures like mortality or major morbidities, but length of stay we showed a difference in. And we hope that as we accumulate these numbers, we will show more benefits.
Question from our audience, Mike Grocott.
I'm very interested. So one of the things now that we most use the cardiopulmonary exercise testing data for is decisions for whether or not to have surgery or what magnitude of surgery. I just wondered how, because of the difference in the environments and the payment structures and everything else, how far down that route you were.
I would say that is a big hurdle and a big barrier, and many surgeons were concerned very much about our doing frailty screening in our clinic because they thought that was going to be the question, and that was going to be the only decision point, and we were going to start recommending that patients not have surgeries. I think it's a very different environment in the United States, but increasingly, with bundle payments, with different payment models, with outcome measures being reported. Chicago is a city that has 6 academic medical centers in it, and they're comparing outcomes of total joints and spines to the guy across the street. And so people want, I think, a better, assessment of which patients they can predict that are likely to have complications, need longer lengths of stays when they go to negotiate payments. If it looks like everybody is the 65-year-old, that hurt his knee or doing sports all his life, as opposed to the 89-year-old, osteoarthritic patient or rheumatoid arthritic patient, they are starting to realize that it's probably going to make a difference in payments. It's probably going to make a difference in reportings and comparisons across, surgeons individually and institutions. So I think that as they start to realize that we're not going to just say your patient's too high risk, we refuse to do anesthesia for you, but that perhaps we can help you get this patient to a better place to have a better outcome, or perhaps we should redesign the surgery. Should they have the mastectomy and the reconstruction, the major reconstruction, or just have the mastectomy, see how they do, get them back on track, and then have their major reconstruction surgery?
Monty, did you have a question?
It's about frailty and physical frailty versus mental frailty. So this is not my area of expertise, but I think I recognise it in patients. You have that physically fit, let's call it mentally frail, and vice versa. How's that matrix shaping up?
So I don't know if you're talking about cognitive dysfunction per se, but even beyond cognitive. So we do cognitive screening. We use the mini cog, and we, in fact, our chairman of our department is very interested. He's a cardiac anesthesiologist in, the cognitive dysfunction and delirium, particularly post-cardiac surgery, and how to identify those patients. But it's interesting. I think it's beyond just that and delirium. I think it's getting a patient mentally ready for their surgery,
sort of what I was getting at,
as well as physically ready.
Yeah.
And if nothing else, to be prepared that this is a tough road ahead, and you're going to be asked to do a lot. And even, there's some nascent studies showing that pre-op depression, the patients are more likely to be even more depressed post-op. And if you have pre-op depression, you're less likely to engage in physical therapy or be engaged in being a true partner in getting through this procedure. They just depend on the doctors to do too much, and particularly in the United States, we're very paternalistic still. You're going to come in, you're going to have your surgery, and patients think that they're just going to go home and do fine.
Yeah, exactly.
And they don't have a role.
Has anyone segmented out, and maybe Mike Grocott knows about this as well, segmented out let's imagine your AT is high, or a 6-minute walk test is great, your get up and go is great, but you're struggling with the clock face drawing, and you're just a bit of a wimp. You don't have resilience, and therefore that is a factor that can result in multiple readmissions, which factors into the... Has anyone segmented out those bits yet? Or?
I mean, I think that's up people have segmented out the cognitive dysfunction piece. And if you are pre-op, have cognitive dysfunction, you're more likely post-op to have delirium.
Independent of physical fitness, though?
I think independent of physical fitness. Would you agree?
I'm not sure how much we've looked at the relationship between the two. I mean, I think you're right. On one hand, we've got a physical fitness literature. On the other hand, we've got a cognitive dysfunction literature.
Anyone put it together?
But I'm not sure they're...
I don't believe people have put it together. Like saying if you're frail from a physical,
we've got the people here. Let's do it. Yeah.
If you're frail from a physical perspective and you're frail from a mental perspective,
cool.
Are they more than additive? And my guess is they probably are. And I think that this whole idea of grit. So if like,
just are you
right? Yeah. Are you willing to push through pain? Are you willing to push through something, suffer some? And I think that's where that gets to that stuff of people who aren't mentally prepared for surgery, even if they're cognitively fine. Just they're a bit of a wimp. They're a bit lazy. They don't exercise. I'd rather not get off the couch. Yeah. Are they going to get up and do what's necessary, to recover from surgery?
So we're getting close to the end. Actually, they're getting ready to turn the lights out.
They are
turning the lights out, actually.
The electricity goes off.
I know, right? So our theme this weekend has been all about enhanced recovery, which is really kind of part of perioperative medicine. Some people look at it as one and the same, actually. How does all of it fit together in what you're doing and kind of what you talk about?
I think that if we don't identify patients who are going to be at higher risk, then we can't start to design and the enhanced recovery programs or apply those. I think this gets back to, we know these failed experiments, like one size doesn't fit all. Routine testing doesn't benefit the low-risk patient. In fact, it increases the risk of the low-risk patient. But, certain testing benefits patients who are likely to have certain conditions. So I think the first step is identifying these patients for have conditions that we know, whether it's frailty, cognitive dysfunction, or a comorbidity that is going to increase their risk. And then applying, because some of these enhanced recovery things do take time and money. Just like you said, there's no freebies, right? And so you want to get the most bang for your buck. Yeah. So you want to take the patient who is likely to be at a higher risk for complications, that has something that we can intervene on, that we have data to show that does make a difference, and focus on those patients first and foremost.
Yeah. A big bang for your buck on that. Well, Bobbie Jean, thank you so much for joining us again here on Top Men Talk. Yeah,
thank you for having me.
Well, hopefully you can come back there. I know that you have had a book, a third edition of a book that you've done that came out this summer. And what is that?
Thank you for mentioning that. It's the preoperative assessment and management. And again, we like to talk. It's a 360 book that is coming from perspectives of internists, anesthesiologists, intensivists, that we believe not only focus on the preoperative piece, but also identifies issues that predict risk inter-op and post-op, a lot of enhanced recovery topics, frailty, anemia management. I hope that people find it useful.
Cool. Very good. Well, Thank you so much again.
Thank
you. And thanks for listening to Top Med Talk at Anesthesiology 2018. Please be sure to subscribe over the weekend. You're entered to win if you're here at the ASA, our wonderful, beautiful, sounds awesome Marshall amp speaker, which is super cool. Follow us on social media.
Exactly.
Oh, wait, did you have something to say about the speaker?
I just keep remembering those people who are listening to this on the replay when it's the most popular podcast in a year's time. We'll work out how to get you the opportunity to get an amp in the future.
That's right. We are. We're going to do this again for sure, because I may actually have to take this one. We'll have to. So thanks for listening. Be sure to subscribe. Be sure to follow us on social media, Twitter, Facebook, LinkedIn, for updates throughout the rest of the weekend. We will catch you later tonight starting at... when do we go live?
2 hours for those people listening around the world in about 2 hours' time.
Yeah, you might be in bed by then.
Or you might be getting up.
But you might be getting up. So hopefully we will talk to you soon. All right, thanks so much. Cheers.
Top Med Talk